Hello everyone. Today we will discuss about approach to inborn error of metabolism. So, starting with its introduction, this inborn error of metabolism, these are heterogeneous group of disorder. Okay, it is a heterogeneous group of disorders. Okay. These disorders occur in which there is a block at some point in a normal metabolic pathway. Okay, so these disorders occur when there is block, at some point in normal metabolic pathway. Okay, so this can occur due to mutations in DNA. So these occur due to mutation in DNA. Next, according to the Garrot's hypothesis, we can see the type of presentation. It can be like any one of the three types. It can be due to any intoxication type or deficiency type or a storage type. So when we come to the type of presentation, when it comes to type of presentation, it can be any one of the three types. It can be due to any one of the three types. That is, it can be due, an intoxication type or a deficiency type, or it can be a storage type. Okay, so for example, when a substance A is being converted to B, with the help of the enzyme E, it is being converted to C. This is a normal pathway. When there is an inadequacy or deficiency of this E in this metabolic pathway, this C becomes deficient. Okay, so when there is an inadequacy or deficiency of E, that is E any enzyme, say for any enzyme is being deficient, it leads to a deficiency of C. Okay, C will not be formed in this. In the same way, there will be a increase in this B and A. There will be a increase in A and B substance. Sometimes this B can take another alternate pathway and can be converted to the D. Okay, this is a substance, D substance. The D substance can be a toxic one, so that leading on to a intoxication type. Okay, so this is an intoxication type, this is a deficiency type, and when there is excess of A or B in that particular individual, it can be leading to storage type. Okay, this is according to the Garrot's hypothesis. This is the formula for every inborn error of metabolism occurring here. Okay, so next we'll see its pattern of inheritance. Next, going on to its pattern of inheritance, 90% of the cases are due to autosomal recessive. Among the remaining 10%, 2/3 are due to X-linked. Okay, are due to X-linked, and 1/3 are due to autosomal dominant type. Okay, this is the pattern of their inheritance. Next, we'll see its classification. So, going on to its classification, first one is amino acid metabolism, second carbohydrate, third lipid, fourth is protein, fifth is any pigment metabolism, sixth can be an unknown biochemical defect. Okay, so Among this amino acid metabolism, we have, so among this amino acid metabolism, we have the defects such as phenylketonuria, tyrosinosis, albinism, alkaptonuria, cystinosis, cystinuria, and maple syrup urine disease, then homocystinuria. Okay, next going on to the carbohydrate metabolism. We have here congenital lactose intolerance, next galactosemia, next glycogen storage disorders. Third, in lipid metabolism, here we have A beta lipoproteinemia, second, lipid storage disorders. Lipid storage disorders, for example, we have Gaucher's disease, Niemann-Pick disease, Tay-Sachs. Okay. Next, among protein metabolism, we have immunoglobulin deficiency, absent or abnormal clotting factors. In absent clotting factors, we have hemophilia, hypoprothrombinemia, we have alpha-1 antitrypsin deficiency. Okay, these are among this protein metabolism. Next, pigment metabolism or pigmentary metabolism. We have porphyrias, second albinism, primary hemochromatosis, methemoglobinemia, Gilbert syndrome, Crigler-Najjar syndrome, Rotar syndrome, and Dubin-Johnson syndrome. Okay. Next, among this unknown biochemical defect, these include osteogenesis imperfecta, Marfan syndrome, and achondroplasia. Okay, so these are the classification among the inborn error of metabolism. Next, we will see in which infant or in which newborn you are going to have to suspect this inborn error of metabolism. So, for suspecting inborn error of metabolism, so these are suspected when they have a history of consanguinity, second, family history of any IEM, third, family history of neonatal death. Okay, or when the child presents with the symptoms when they start or change the diet. So when the symptoms accompanying when they start or change the diet of the child. Okay. Fifth, when the child have a unexplained seizures, or when the child presents with recurrent vomiting and diarrhea, or unusual odor of the urine, or when there is an unexplained death in the first and second degree relatives, when there is an unexplained death in first and second degree relatives, or when the mother have an acute fatty liver during the pregnancy. When the mothers have a acute fatty liver or a HELP syndrome during the pregnancy, we can expect the child to have a long chain fatty acid defect, that is long chain hydroxyacyl coenzyme dehydrogenase deficiency. Okay, or when the child has a rapidly progressive encephalopathy, then that is rapidly progressive encephalopathy. Okay, in science, when will you suspect the child to have IEM? When the child have a coarse faces or coarse features, when the child is dysmorphic, when the child has an unexplained shock, that is the child is critically very ill with unexplained shock with persistent tachypnea, when the child has a abnormal visceromegaly, that is both hepatomegaly or splenomegaly, when the child has an unexplained cardiomyopathy with decompensation, okay, when the child presents with temperature instability, seizures I have told in the previous thing, when the child presents with failure to thrive, when the child have mental retardation or critically ill newborns, you can have this IEM as your differential diagnosis. Among the lab investigations, when the child presents with a persistent hypoglycemia, when the child has persistent acidosis, third, when the child has hyperammonemia, or when the child presents with ketosis or low uric acid level in neonate with metabolic alkalosis. Okay, these are the conditions in which you should suspect a child having a inborn error of metabolism. Okay, next we'll see their pattern of presentations. Their patterns of presentation. First, when the child presents with encephalopathy, can present with encephalopathy with or without metabolic acidosis. Here first we'll take out without metabolic acidosis. So encephalopathy without metabolic acidosis. So what are the examples you have here are urea cycle disorders. Second, maple syrup urine disease. Third, non-ketotic hyperglycemia. Fourth, cobalamin deficiencies. Fifth, I've written only few examples for this. Okay, folinic acid responsive seizures. Okay, sixth is pyridoxine dependency. Next presentation can be encephalopathy with metabolic acidosis. So in children with encephalopathy with metabolic acidosis, they can have organic acidopathies or congenital lactic acidosis. In children with fatty acid oxidation defects. Okay, this is the second presentation. The third presentation can be acute liver disease. In acute liver disease, the child can present only with jaundice When the child presents only with jaundice, it can be due to Gilbert syndrome or Crigler-Najjar syndrome. Or when the child presents with a hepatic failure, this can be due to tyrosinemia. Second, galactosemia. Third, glycogen storage disorder type 4, or it can be due to neonatal hemochromatosis. Okay. Next, the child can present with neonatal cholestasis. So example for this presentation are alpha-1 antitrypsin deficiency. Second, Niemann Pick disease type C. Okay. Or when the child can present with persistent and severe hypoglycemia. The child presents with persistent and severe hypoglycemia. This can be due to galactosemia, fatty acid oxidation defect, or glycogen storage disorder. So next type of presentation can be dysmorphic features. So in this dysmorphic features, they can include paroxysomal disorder, second, pyruvate dehydrogenase deficiency, third, lysosomal storage disorder. Okay. Or the child can present with a cardiac disease like cardiomyopathy with decompensation. These include glycogen storage disorder type 2, that is Pompey's disease, and fatty acid oxidation defect. Okay, so these are the some of its presentation of children with IEM. Okay, next we'll see it's how do you go on with your lab diagnosis. First, when you suspect a child with metabolic disorder, you are going with a plasma. You have to do a plasma ammonia level. Okay, so you will classify it as having high ammonia or normal ammonia. Whether it is high or normal, next you have to do a blood pH level. Okay, when the blood pH level, whether it is normal or you have acidosis. So in a child with a hyper ammonemia, that is high ammonia with a normal pH, it can be due to urea cycle disorder or urea cycle defect. Okay, when the child with high plasma ammonia with acidosis, next you have to look for ketosis. When there is no ketosis, only the child has hyperammonemia with acidosis with no ketosis, the defect is fatty acid oxidation defect. Okay, or when the child have high ammonia with acidosis and with ketosis, everything is present. Next, what are the defect it can be? It can be organic acidemia or mitochondrial disorders. Okay, next, here it also same, it applies same. Okay, when the child has normal ammonia with acidosis with no ketosis, it can also suspect fatty acid oxidation defect. Or when the child has a normal ammonia with normal blood pH without any acidosis, then you have to suspect this phenylketonuria or non-ketotic hyperglycemia. Okay, next, when you find that the child has a urea cycle defect, what will you do next? You have to do a plasma citrulline level to find out which enzyme is defect in the urea cycle. Okay, when this plasma citrulline is very high, it is due to ASA deficiency, that is arginosuccinic acid deficiency. Next, when this plasma citrulline level is normal or when it is between 20 to 50 micromole per liter, you have to do urinary arginosuccinic acid level. When this is present, when urine arginosuccinic acid is present, it is due to arginosuccinic acid lyase deficiency, that is called as arginosuccinic aciduria. Or when this is negative, when this urine ASA is negative, then it can be a transient hyperabonemia of newborn. Or when you cannot detect, or when this is undetectable, which when plasma citrulline level is when it is undetectable, you have to do urinary orotic acid. Okay, when this urinary orotic acid is positive, it is due to ornithine transcarbamylase deficiency. Okay, when it is present. When it is negative, it can be due to CPS deficiency. Okay, this is about how you go on with the child presenting with a metabolic disorder. Okay, next, when the child has a persistent hypoglycemia, how will you go on with it? When the child present with persistent hypoglycemia, you have to look for urine non-glucose reducing substance. Okay, in urine non-glucose reducing substance is positive, then you can diagnose it as galactosemia. Okay, when this is negative, next you have to look for urine ketones. When urine ketone is positive, this can be due to glycogen storage disorder or gluconeogenic defect, or it can be organic acidemias. When this urine ketones are negative and this urinary non-glucose reducing substance is also negative, it is due to fatty acid oxidation defect. Second, it can be due to hyperinsulinemia. Okay, this is about the approach of a child with a hypoglycemia. Next video, I will talk about the investigations. Okay.